Okay, hello everybody. Good afternoon for those in the United Kingdom and of course those in Malaysia. Good evening, and everybody in between is like between evening and afternoon. Welcome to this session, and this is the last of Around the World in 80 days, and I got the best for last. So it's kind of tricky because you wonder what else to talk when everybody has presented. So let me just start by sharing my screen. Okay, oh gosh, this way. Let's do that. All right, I believe you can see my screen now. Let me just try and
Yeah, we
adjust
can
it.
see that.
Because I haven't been, is that okay?
You just
Like
need to
clear?
full screen. If you can just full
Yeah.
screen it.
Have I done it as full screen? I thought I've done it. Oh gosh.
There it is. That's it. Thank you.
Yeah, all right, good. Right, so as you notice, this is an unusual topic. It talks about odontogenic cysts and dental pathosis. But let me just start by introducing myself briefly. I'm an oral maxillofacial surgeon. I work in the University Malaya, based in Kuala Lumpur. We are proud to announce that the university has gone to number 58 in the ranking for the upcoming year. And as you have heard, I've been using EthOss since 2019. So if you look at COVID and pre-COVID, that's how long I've been doing that in Malaysia when they first started bringing in the bone graft substitute here. Right. So as I said, the lecture I'm going to do is going to be a bit difficult because everybody has talked a lot about all the clinical stuff and things like that. So what I'm going to do, and this a bit academics, I would say, I'll give you a bit of updates on some common odontogenic cysts and the treatment. We talk a bit about grafting the cystic lesion. Should you or should you not graft it? Then I'll introduce you to this thing called dental implant pathosis or retrograde periimplantitis, and I'll round off the whole thing with two cases of mine that happens to be managed using EthOss. So let's move on to begin with. A cyst is a pathological fluid-filled cavities lined by epithelium. Normally, we don't see that clinically. As you can see in this picture, we actually remove some bone and you can see some cystic lining beneath it. It can be derived from rays of Malassez, reduced enamel epithelium, dental lamina, and of course, it can be of non-dental origin. Clinically, radiography, they be sharp, defined radiolucency with smooth borders, as you can see in these two images. And some clinical features will be that usually they are fluid filled that can be aspirated, thin wall cystic lesion that can be transluminated. It grows slowly, displacing rather than resorbing teeth, symptomless unless infected, and are frequently a chance radiographic finding. It's rarely large enough to cause pathological fracture, but it forms compressible and fluctuant swelling if extended into soft tissue. It may appear bluish when enclosed to the mucosal surface. This is actually just an illustration to show different type of cysts. Okay, the copyright is to the owner of this image. And normally we classify them into two, that is odontogenic and non-odontogenic cysts in this case. And most of the odontogenic cysts will be either developmental or inflammatory. And the list of cysts that we have is that much here. So I'm not going to go through all of them, unfortunately. We don't have the time. And it may be too boring otherwise. Okay, so dentigerous. I'm sure you heard about this. You may have seen it in your practice. You may have referred patient if you're not an oral surgeon. It's a cyst that originates by the separation of the follicle around the crown of an unerupted tooth and is there because of a cystic change in the enamel organ, and most commonly is the most common developmental cyst. The cause is unknown, unfortunately. It manifests in adolescent and young adult, often in the region of maxillary or mandibular molar. So as you can see in this image, it is well-defined, expansile unilocular lesion associated with an unerupted tooth. Important diagnostic point is that it's attached to the CEJ of a tooth, and the whole tooth is actually involved in the cystic lesion. So you can actually see the whole crown inside the cystic cavity. In terms of prevalence, it's about 15 to 18% of the jaw cysts more in male than female, and how we treat it is by marsupialization or removal of the cyst and the tooth. This is an example of a case that we've done. You can see there's some radiolucency. There are two teeth here, but one of them are impacted. And this is how it appears in the three-dimensional radiograph. And you can see some part of the wall is even breached. So it can grow quite large. And this actually the clinical photo showing the removal of the cystic lesion and the tooth that is involved in that. The other way of doing treatment is that to marsupialize or decompress the cyst. So in this case, what we have done, we open up the cystic lesion. You can see a cystic lining. After that removal for biopsy, we actually put a tube there. So that actually will decompress, let bone grow, and we actually went back in later on because the cyst is going to be easier when there are more bony wall, and you don't cause so much damages since it's not a tumor or non-cancerous as well. Okay, next, moving on is another very common cyst. All right, I'm sure everybody heard about this. Odontogenic keratosis. The etiology, unfortunately, is uncommon, and it may probably originates from the primordial odontogenic epithelium. It has been categorized as cyst, then as tumor, and now we're reverting it back to cystic lesion. A tooth is sometimes missing. It forms about 10% of odontogenic cysts, more common in male and female. And there are two peaks, young adults and those in the 50 to 60 age groups. Location is more common in the posterior mandible and the mandibular body and ramus. It may be associated with a syndrome called nevus basal cell carcinoma syndrome or Gorlingos syndrome. In terms of histology, autokeratinized will form about 30% of it. And in terms of treatment, there'll be either enucleation or marginal resection. Professor Stollinger actually advocates enucleation rather than resection. But for either cysts, they do recur, and they are more commonly recur if it's a parakeratinized version of OKC. One of the way to reduce the recurrence will be to actually marsupialize it so that it gets smaller, easier to treat than having a large massive cystic lesion. And that has been shown to reduce recurrence rate if your patient and you are able to be waiting long enough for more bony wall to grow back before we went into enucleate the cyst. Right. Radiographically, it can present as a well-circumscribed unilocular or multilocular lucent lesions with well-corticated borders. It can mimic other cystic lesions like the dentigerous cyst that you've seen earlier or ameloblastoma. So this is one case where there's a recurrence. If you can see this X-ray, somebody, or actually my colleague has did an operation on this person. There's a tooth inside which was left. All right, you can see there's some cystic lesion. That's in 2011. If you're moving on, you can see on different section how the cyst appears to be like. It's hollow. And well, he went in, he removed the cyst. And this is what's left there. But then if you look again in 2015, you can notice that there will be more cystic start growing again in the jawbone. So we went in again and enucleated it. So of course, the work never ends, unfortunately, with OKC. Now moving on is another cyst that is what we call periapical or radicular cyst. It forms the majority of jaw cysts. That's about 50 to 75%. Most often it's a chronic swelling, and most of them are in the maxilla around non-vital incisors, canine. It's related to inflammation due to trauma or decayed tooth that has turned non-vital. So radiographically, it's usually less than 1 cm, as you can see here, well-defined unilocular. Lucent lesions at the periapical region at the tooth, like you can see here. And if we take out this tooth, for example, and you leave it behind, it will actually remain as residual cyst. So how do we treat that? Often we try and do a root canal treatment. We remove the tooth if necessary, or if the prognosis is bad. But we have to bear in mind, we have to clean it up properly, otherwise we get residual cyst. So the treatment will be enucleation of cyst with or without episectomy, decompression of cyst, followed by surgical enucleation and curettage, and the success rate is very good. So unlike OKC, you get a very good success rate, 95% without recurrence. This is an old case. If you notice, this is 2006, where we treated the patient with a swelling on the circular area, radiolucency at the apical of the upper incisor. And we actually went in, enucleated the cyst, and did episectomy. Of course, you may notice this is an old case where we use metallic filling. We don't do that anymore, right? But then you may get a very huge cyst, like what you've seen in this image. You see, it's huge. It's good here, but it's like almost to the midline. There's even a little small cyst here. And if you look at the cross section, you see the cyst is large. And if you go further, you see that it's getting larger and larger, and the wall is thinner and thinner. So the problem with this kind of cases is that if we were to go in and try to remove everything, we will end up in the sinus or in the floor of the nose, right? So you see that is huge, really huge. So in this case, it may not be a good reason to enucleate. So if you notice, I put decompression of the cysts, and this is what we have done. We actually did the same thing like what you saw in the previous picture. We opened up the cavity because we need to biopsy the cyst anyway, and we put a ETT tube, anchor it, and patient actually walk around for like 8 months to a year even. It really depends on the progress. But having said that, the beauty is when we went in, you see that, that is the site where the tube was. That's what has happened. We remove the cystic lesion, and the amount of cystic lesion that we actually has to remove is a lot smaller, as you can see in these images. So that's the beauty about decompression if the lesion is not an aggressive tumor or cyst. Right, moving on, we got residual cyst that is a round to oval radiolucency of variable size within the alveolar ridge of the site of previous extraction. Of course, this is a really huge one from the textbooks. Right, what we have here, this patient has a cystic lesion or some swelling, which we removed surgically and was found to be a residual cyst. So in summary, you may have seen that. So we have three main treatments for bony cysts: enucleation or cystectomy, decompression followed by enucleation, and perhaps bone grafting as the third option. You notice all the cases I've mentioned, all the literature I've been talking about, do not talk about bone grafting. So do we bone graft it? Okay, do we put bone graft into the cystic lesion after enucleation? Right, so the problem is that this is kind of a bit controversial. Yeah, I mean, for us, most of us in oral surgery that we are trained, we do not do that. But having said that, is there a benefit? So this author North, for example, says when the size of this defect is large, 1 to 2 cm or 50% of the circumference bone, go and graft it. Whereas others says, you can get complete spontaneous healing of large jaw cysts, and defect as large as 10 cm can achieve complete healing within 1 year. So there's always, two school of thoughts, and then you'll be wondering, sometimes I'm sure you may have seen patients, either your patients been sent to somewhere else or treated by some other colleagues, and, you may find that, hey, my patient's having a graft. Let's look at this literature that was published in 2011. It says filling or no filling after enucleation, a review. So this is a list of papers that they look into where there is no graft being put, and they actually found that it works. The defect close up. And this is what they summarize. The complication rate for cystic enucleation, primary closure, and peri-operative antibiotic seems to be less than 5%. So that's good, right? You don't do anything, you get very low complication, even if the defect is larger than 3 cm. And fractures after enucleation or mandibular cysts are extremely rare. A fracture rate of 3.6% in a study of 160 patients, presenting at the follicular, at the mandible angle with a mean size of 31.5 mm. That's like 3 cm, 1.5 inch, for example. Okay. And ossification of defects up to 3 to 4 centimeters can be expected in 12 months. So if you don't do anything, it's not bad, isn't it? Right. Then there's another group of patients where they receive graft. It can be autograft, collagen, beta-3CP and blood. You notice that. Nanoparticle hydroxyapatite, carbonated apatite, for example. And what do they say? It's like we all agree autologous bone is the gold standard. It has been used actually for cystectomy since 1958 with bone taken from the iliac crest. But clinical reports actually, you want to look at what is a success rate. It's actually quite rare. It's very difficult to find. And when it comes to allogenic freeze-dried bone, all right, what the literatures tell us is it's been used several times for defects, and you get complication that's ranging between 17 to 25%. Not very good. Okay, the next bone will be xenograft. The first one that found, all right, is actually this Q bone, right? It was used in the orthopedic cysts in 1961, but it bear an increased rate of infection of 20%. But having said that, if you look at that, this is 2022. In this case, they actually did a GBR with bovine bone, all right, and it seems to be okay, So again, you always get stuck and say, do I do it? And then somebody else tell you with certain different experience and things like that. And this is another one, 2024. It says clinician should consider the patient specific. So that is like, it's trying to tell you, don't do that for everybody. The next will be allograft. Okay, alloplastic, sorry, not allograft, alloplastic or synthetic materials. It has low or unpredictable resorption and occasionally inflammatory reaction. And what has been said is that clinical experience exists for tricalcium phosphate, hydroxyapatite. But if you do follow EthOss webinar, all right, one of it is actually using a modern regenerative approach to treat cysts and episectomies by Dr. Fairbairn. He actually was showing us how he did use EthOss in cystic cavities. Yeah, all right. So I mean, I'm looking forward to see the outcome for all the cysts that he has done with EthOss, because I can't really find it in the literature anywhere. Right. So what do we summarize from that? Complete jaw ossification takes about 12 months after enucleation, or simple mucoperiosteal closure. It means that if you close it nicely for defect that's up to 3 cm, it works. If you have a larger defect, you wait up to 24 months, and then it still seems to work. The gist is the periosteum, all right, and the bone walls. They should be there. They have to be there. And which is why I was saying, if you do a decompression, the wall will start growing back. And then that's the most important thing about bone healing. And spontaneous bone regeneration can be delayed in older people with bicortical or circular defects. So if you have those defects, we will be having a little bit of a problem. Okay, right. So then this other paper will tell you after a mean observation of 12 months, okay, a sufficient amount of bone again forms. And this is from a paper in 2018. And more recently, 2022, a systematic review looked into spontaneous healing, as you can see here. And then they look at different type of bone graft, like here it says bovine, hydroxyapatite, okay, eggshell-derived HA. And there's actually 2 papers that they quoted that compares between cases with bone graft, without bone graft. And what did they find? Over 90% of bone regeneration occurred within 6 months after bone grafting. Bone regeneration rate after cystectomy showed great variation ranging from 50 to 100% after 6 months, but reaching about 90% after 12 months. So it's good. It looks good, isn't it? Yeah. And then over 80% of bone healing occurred within 12 months after bone grafting, regardless of the type of graft material. So again, it was a good candidate for that. I think that's in everybody's mind, because that is in my mind as well. Bone grafting may have some advantage in early bone regeneration within 6 months, but spontaneous healing could be satisfactorily achieved in 1 to 2 years. So you need to wait. And that's where the argument is. And then say, do we put it a graft and try to make the healing faster and things like that? All right. Having said that, there is problem with bone graft. Failure of bone graft is related to these few factors like smoking, pre-op infection, last cyst, third molar inclusion, peri-wound osteosclerosis, and the use of non-autogenous and autogenous mixed bone. So this study in 2017 tells us that there is a potential problem with graft, and these are the risks. Okay, moving on, I'm going to say about two different things. I mean, another different thing. Then I'm going to merge these two different things into the case I'm going to show you. Something we call endodontic implant pathosis or retrograde peri-implantitis. So it's actually the infection and the disease that process that occur from the endodontic issue of a tooth next to the implant, or it can be vice versa. All right, it can manifest as what we call retrograde peri-implantitis, or it can be a form of infection around the implant. All right, so normally they may be with or without abscess. It may have a sinus tract, and the expansion of apical pathology located at the natural tooth adjacent to implant may result in radiolucency seen in radiograph. There are several factors that has been reported to cause this. One is pulpal periapical lesions in adjacent teeth, the residual disease causing microorganism in extraction socket after extraction of the natural tooth at the implant site due to infection, excessive heating or compression of bone during implantation, contamination of the apical of the implant during implantation, and other factors like EBV, CMV virus. Right, there is a classification about this, but I'm not going to go into detail because we don't really have too much time. I'm just trying to stick to time that's allocated for everybody. You do notice the, what do you call it, the reference there if you're interested to read more about this. And if you look at this paper, all right, it actually talks about periradicular endodontic implant in apical region of adjacent implant. So this is one of the earlier paper I managed to find, okay? And there's 98. So what is the treatment that has been advocated? Implant removal, surgical excision of the periapical lesion with or without biomaterials, decontamination with abrasive device and laser, decontamination with brush and grafting, and lastly, they even do implant episectomy. Right, so this is a more recent paper, if you can see that in 2020, okay? So they actually talk about it being a new disease entity. And yeah, I'm just going to scroll and show you more and more papers that kind of pick up, not all right? And you see here, successful treatment of large implant periapical lesion that cause paresthesia and mandible. In this case, they actually grafted the site as well, all right? And for those people who read dental updates from the United Kingdom, there is actually a very quite recent paper, 2023, about this problem. There is also a flow chart that tells you what you can do, right? When you have this situation. As I said, I can't be going in, but you do find a reference here that it may be useful for you. And as said, with the big lesion here, what did they do? They curate it, okay? They clean up the implant surface, they graft it with xenograft, bone substitute and covered it membrane, and seems to work. And the paresthesia, if you notice, there's a word paresthesia and perimandibular abscess, all resolved in this case. Right, but mainly what you have seen is all about infection. How about cystic lesion? All right, there's one paper I managed to pick up. If you notice that, it says immediate dental implant failure associated with nasopalatine cysts. So there's actually a cystic lesion. This is quite an old paper in a way. So you can see the image is not as clear as what we have with digital version nowadays. And this implant were actually lost due to the formation of cystic lesion that goes into the implant site. Right, having said that, this is the cyst thing that I want to tell you about, right? This patient was referred to us some time ago in 2018 or 19, if I can't remember. I can remember very clearly because this is a pre-COVID for sure. And you do notice there is a root treated tooth, there's an implant being done, there's temporary crown, but then the dentist noticed that this swelling actually was enlarging over a period of time and includes the dental implant as part of the cystic lesion. Right, so what is the size like? It's like 7 × 9 millimeter, okay, using CBCT. So what was the option? All right, root canal treatment was reasonably well done. All right, the site is asymptomatic. There's nothing there, no pain, not swelling, no infection, things like that, no fistula. But radiographically, there is an expansion of the swelling. So what we did was to open it up. As you can see in this image, you can see something showing through because that's the metal and that's the implant. This is the cystic lesion actually, right? And that was the cystic lesion after we remove it. And what we do now is to clean the wall with degranulation burr, clean the implant surface with titanium brush. You see that shiny after we clean it. We just do episectomy on the lateral incisor since the root canal has been done, and it was quite good to need a redo because we are not sure whether a redo or root canal is going to be successful. So we did episectomy, and this is also the early times I was using EthOss. All right, the earlier days, 2019. And we actually used that to cover up the metal that you're seeing here. That's the EthOss that has been put into that. We actually pack it, close up everything, wound heals reasonably well. We lost the patient during COVID because he actually works overseas, but this is how the appearance of the bone graft material that we put in. Well, we didn't really fill up the whole space immediately because it's huge, but my intention was actually to cover the implant so that any remaining or residual cysts that's going to form again will not go and encroach into the implant surface. So that was the intention. And this is the post-op radiograph. And this is the last radiograph which we managed to get from the referring dentist. Not very clear have to admit that, but you can see there's some bone around the episected tooth. And there is something there, but I don't know whether this is a radiolucency or not. And I don't know, I'm trying to get the patient later radiograph, preferably a small periapical instead of a panoramic. But this is what we managed to achieve. He has been asymptomatic all the while, ever since before the operation is after that. So, and you've noticed that the dentist actually made a crown onto that tooth afterwards. Right. The other lesion that is of concern is recurrent OKC. I've shown you how bad they can be, how bad they can recur earlier on. If you can notice the case that my colleague has done, that we have done, we're going back in and clean it again and things like that because they are famous for having high rate of recurrence. And in this paper by Toast to North, all right, it talks about surgical treatment algorithm for OKC. And they actually have a case here. You see that there's a lesion, there's implant there. So they have to go in and do a treatment because this odontogenic keratosis recur. And what they did was the osseous wall was forcefully, I'm just taking words for words from the text to be clear, curated. Pineapple burr were used to remove 1 mm of bone around the cavity, attempt to preserve the nerve, and an implant second premolar apex that is close proximity to the cystic cavity was also burnished. Okay, so they actually cut it or something like that to try to keep the implant. So in this case, the implant remains apparently. I do have a case that's something like that. It all started in around 2002. This patient was treated by a senior colleague of mine with some sort of cystic lesion. You can see our radiography at the time is a occlusal view, panoramic view, showing some lesion, maybe some root resorption here. And she underwent surgery. So I don't have the details, unfortunately. She wasn't my case until my colleague has retired. And then after they go over the case, this is what they have in 2011. So they actually put implant to restore the missing teeth, but you can see there is too little lesion there. Having said so, but fast forward to 2019, this is how she presented with a radiograph at that time, 8 years later. You can notice, I'm sure you will agree with me, the cystic lesion has enlarged. So we know there's a recurrence, all right? We can't ignore that. So we did a 3D radiograph. You see there's bone loss, bone loss. If you look at it in cross-section, you can see a lot of bone loss here, okay? A lot of bone loss. So it's kind of a tricky situation in this case. And see that? The implant is actually in the recurrent cystic lesion in this case. So what we're going to do now, this is just showing you all the different cross-section, okay? So we went in a bit like the other case earlier on that you saw. We went in, raised a flap, and you can see the wall expanded. You know, the wall that you saw on radiograph is like the missing wall. Actually, it's not missing. It's that thin. It's very thin, like eggshell, which is why we can't see it. But this is the cystic lesion. After you remove some bone, you can see a cystic lesion. We remove the bone, you see more cystic lesion, which we curated out. And ta-da, you may see something here now. Okay, that's the implant. So we did scrap and everything. We clean. There you go. After all the cleaning, you see raw, bone here. You can see all the blood bleeding have been stopped. Same trick that we did earlier. You do the degranulation burr to clean out all the surfaces. And I did clean the implant surface exactly like the other case. All right. And this is actually the floor. I can't show you much, unfortunately. That's the floor of the cystic cavity. There's actually a nerve there, right? It's quite low. So you can really see the inferior alveolar nerve somewhere down there. It's bleeding actually. So that's EthOss in action. We put it in, we pack it, it looks good when I pack it and they say, yeah, it's a bit like the other case. But I would put the but here because this is what happened when I saw the patient afterwards. It's like, oh my God, what's happening now? So we thought we cleaned up the surface and then we thought we cover up with bone graft material. So I didn't really fill it up anyway, because when you fill up an OKC with bone graft, it's going to be a nightmare to try and decide whether you get a recurrence in the future or it's just some bony defect from your bone graft. So having said so, remember I was telling you that's the inferior alveolar nerve. The bone graft now is actually on top of the nerve. Okay, so you may want to have a guess by yourself and say, wow, what's going to happen to my patient now? Okay, I'm going to tell you the good news, all right? From the cystic lesion was followed up, nothing happened. From this case, I've realized because it's quite a good material, it's quite inert to nerve actually. So it's actually in contact with this patient's nerve, but she didn't get any loss of sensation. We have read reports like calcium hydroxide going into the canal, causing numbness and things like that. And it takes about 2 years to resolve. Now, it doesn't happen to these patients. So I'm pretty confident. So if I have a nerve, not on the cyst, but like a mental nerve, when you need to do a GBR very close to it, I'm glad to say I don't really have much problem with that. Okay, most of the patients that we have used EthOss in the area with nerve do not seems to have adverse effect at all. So I'm till the end of the lecture, so I'm keeping up to my time allocated. I would like to invite everybody to this meeting in Warsaw that is in October. There's a QR code here, and I'll be there. All right, and of course, I'll be happy to mingle with everybody. We share experience of different type of cases, different use of EthOss material and things like that. So may I end this lecture by welcoming you to Malaysia if you do pass by. I happen to be at this angle in the hotel room, so I managed to capture all this. So, I just want to share this nice view with everybody, and I wish you had the chance to see this yourself. Thank you very much. Okay, I'm going to stop sharing now.
Thank you. That was an excellent presentation. Very, very interesting. We've received no questions from people thus far, so I'm just let everyone know if you do have any questions, please use the Q&A box at the bottom or the top of your screen. I've just got a couple of questions for you, if that's okay. And what I want to know is, I was wondering, what are the most common mistakes that are made when managing cystic lesions?
It's difficult to say it's a mistake because, everybody have a different experience. And the first thing that we do with most cystic lesion is we're just guessing what they are. So we need to biopsy them. And when we biopsy them, sometimes if it's small, we try to clean out everything. You interpret the whole thing. The problem arises when it comes back with an OKC in the name. So it's like red alert. They have a very high recurrence rate. They have been reported to recur even 10 years, 15, 20 years down the road. So it's not a mistake in a way of speaking, but then it's like when I'm going to clean it, I'm just going to clean it as I'm doing for every other cystic lesion until it comes back and say, now what? Because you get you get a name that's telling you it's going to come back. We just do not know when it's coming back. In fact, when I was doing this webinar, I went through one Professor Stollinger's paper, and he actually mentioned you need to enucleate it. You need to put some chemical solution called carnal solution, which is what we're doing in uni, right? So in those cases, when it's the first time, when you see the case, when you do not know, we don't do it because carnal is actually toxic. If it's in contact with the nerve will get kind of chemical reaction. Patients will turn numb with that, unlike when I saw with my EthOss cases. And but then when there's recurrence, that's what we do. You see that we're scraping the bone. Just now we're showing you. We put chemical, which I'm not showing you here because I didn't do that in these two cases. But that's what we do with OKC. The other cystic lesion are more manageable. So I don't think it's a problem. Sometimes we do leave residue and then they recur. Yeah, we know that. You can't see it. You see that's problem.
Okay, thank you. And just to recap, how do you decide when it's appropriate to graft a cystic site over versus doing an alternative treatment?
Yeah, that is the tricky question because I did put down the whole list of papers. I think there are three main papers. And I mentioned earlier, we don't graft it in oral maxillofacial surgery. Most of us are not trained to put something there. Because the whatever experience in the past by the mentors, by the senior professors, by somebody years ago, of that experience, they actually tells you bone form. Now, the problem with bone form doesn't mean they're going to form completely. So if your bone is this white, if you remove a cyst and bone form, they may heal, but the bone is going to be this narrow. So it's okay for some cases because if I'm going to do it on, near the nose, for example, I'm not going to put implant or anything there. So I'm not be bothered. I'm not going to be bothered if the bone is lacking. But then if you're looking at where the alveolar region, yeah, we are concerned. And we are actually talking about cysts in the oral region. But if you look at the literature in the medical, they're having the same issue to put or not put. And in some situations, they actually put bone graft in the cyst.
Okay. Very interesting. Okay, and finally, just I know that you are going to be going to the Regenerating Beyond Boundaries Symposium. Could you talk to the audience a little bit about this event and your involvement with the event?
Right. Okay. I've told you about the event just now. Talk everybody about the event. The date is October and towards 24th, 25th, 2 days. Right. Apparently it's interesting. I went through the website actually. I've seen all the speakers, so I'm the only one from Asia, apparently. And the topics is going to be announced very soon. I think the scheduling. So you may keep an eye for what is going to be presented because I can't tell you what are the topics. But for my case, I'm going to talk about my experience with EthOss, how from being a skeptic fellow, I would say skeptic because I really do not trust it in the beginning. It's like a powder kind of thing, but it seems to work. All right. And I would like to share some of the experience with, a bit like these cases, but there are different cases, some large, some small, and different use. And hopefully, with other speakers, we can actually gain more experience and evidence to say, well, this is one good alternative because for most of us in Malaysia, I mean, there will be racial and religious issues about certain material not compatible with people with certain religion. So in a way, it was kind of break those barrier because it's like synthetic material. So I look forward to everybody coming. I'll be there. Yeah. All right. And see you there in Poland.
Fantastic. Thank you. And thank you for ending the series with us with your excellent presentation. And thank you everyone for joining us today. And if you've joined us along the journey over the last 80 days, if you do have any questions, please do send them to info@ethos.dental. We can pass them on to Professor Ngeow and then we can get those answered for you. Also, don't forget to join or have a look at the EthOss Case Studies group on Facebook. It's got 12,000 clinicians all sharing cases that work, that don't work, and it's a fantastic environment to learn. Thank you once again. Thank you, Professor Ngeow, and look forward to seeing you next time.
Thank you, everybody.
Thank you. Bye.
Bye.